This is Fanta Wasif from Golia University College of Health Science, Department of Public Health, lecture notes on emergency nutrition, course for summer track students, MPH. Chapter 4, Therapeutic Feeding Programs. At the end of this chapter, the students will be able to understand the concept of severe acute malnutrition and secondary time to establish severe acute malnutrition setting for therapeutic feeding programs. 4. Treatment phase for therapeutic feeding programs. There's admission criteria for therapeutic feeding programs. 6. Treatment and care of children 0 to 59 months. 7. Feeding children 6 to 59 months. 8. Food provides sensory stimulation and emotional support. 9. Failure to respond treatments and discharge criteria for therapeutic feeding programs. 11. Different approaches to the management of severe acute malnutrition. Then finally, time to close severe acute malnutrition. When it comes to the concept of severe acute malnutrition, you see, severe acute malnutrition is a stage at which the life of the individual is at increased risk of death. In other words, it is a stage at which urgent medical and nutritional interventions are required to save lives. The goal of therapeutic feeding program is saving the lives of and rehabilitating severe malnourished individuals. Therapeutic feeding is a complex medical nutritional care that requires maximum efficiency. It requires sound medical and nutritional knowledge and experience, as well as clear understanding of protocols and procedures of therapeutic feeding. When to establish therapeutic feeding programs? The 2004 Emergency Nutrition Guideline recommends that therapeutic feeding program is established when the number of severely acute malnourished individuals exceeds the capacity of the local health facility or system, or when the prevalence of severe acute malnutrition sum is greater than 3% in manifesting bilateral edema. Other sources suggest that therapeutic feeding program should be established when the global acute malnutrition levels indicate critical alert status. When it came to the treatment modalities, the principles of management severe acute malnutrition comprises 2 settings and 3 treatment phases. The 2 settings, outpatients and inpatients. The treatment phases, phase 1, transition phase, and phase 2. Let's come to screening and admission criteria for severe acute malnutrition. Effective identification gives access to largest number of children to the program. There are 3 anthropometric measurements that are used to screen and identify malnourished cases, and also 1 clinical assessment method, which is okay? The mark way through it. These are the 3 important tools that are used to screen and admit the severely malnourished children. This is all about the calibration of measurement tools. Measure each height in board with 110 centimeters thick. Like these 2 people are adjusting or calibrating the height. The scale ones measure each scale with a standard 5 to 10 kg weight. Okay, before even this is a digital filter scale, should be corrected and adjusted. Mark tab, measure each tab with a plastic pipe of 20 centimeter in circumference. Look what do you feel from here, okay? From this headboard. Okay, these numbers are not available here. So this will lead us in the wrong data and will conclude the wrong information, and the treatment will be failed. Let's come to checking for bilateral edema. Bilateral edema is the silent kwashiorkor. Kwashiorkor is always a severe form of malnutrition. Children with bilateral edema are directly identified to their acute malnutrition. These children are at high risk of mortality and need to be treated in a therapeutic feeding program. In order to determine the presence of edema, normal temperature is applied to both feet for at least 3 seconds, okay, like that of 101, 102, 103. If a shallow print persists on the both feet, then the child has edema. Only Children with bilateral edema are regarded as having. Let us look. Ring testing. Grade 1, mild, both feet or ankles. Grade 2, moderate, both feet plus lower legs. Grade 3, severe, generalized bilateral pitting edema, including both feet, legs, arms, and hands, like this kid, look, this child. Okay? When it comes to the mid-apparent circumference, measure amount of the tissue in the arm. Another measure of thickness of fibers. It reflects muscular density. And measurement taken to the closest millimeter. Measurement taken on the left arm. That's not necessary. The left arm is. The mark is preferred indicator for identification, diagnosis, and treatment of children with active malnutrition because it's a need to identify children who are most risk mortality due to the active malnutrition. Mark less than 11.5 centimeters or a weight for it less than -30 square based on the WHO standards in children 6 to 15 months. It is simple to use, allow community health workers and volunteers to identify and refer children to health facilities, okay? It's simple and cheap, improves efficiency of the program size. It is also prone to mistakes unless carefully measured that you should have to consider here. It's prone for that leads to a mistake. It is a better indicator of mortality risk associated with malnutrition than with but nowadays there are studies that fortify it. So it's better to read. Mark less than 11.5 centimeters or edema refer to it, and mark greater than or equal to 11.5 centimeters and less than 12.5 centimeters is referred to target supplemental feeding program. How to measure milk? First one, explain the procedure to the child's mother or caregiver. Second, if possible, the child should stand erect and sideways to the mirror. 3, bend the left arm at 90 degrees to the body. 4, place a measuring tab along the upper arm and find the midpoint of upper arm. The midpoint is between the tip of the shoulder and the elbow. 5th, mark the mid-upper point with a pen. 6, let the left arm hand relax it at the side of the wound. 7, place the mark measuring tab on the midpoint. 8, pull the tab until it fits securely around the arm. The tab should not be left too slack nor too pulled tight. The tab should touch the skin all the way around the arm, but not make a dent in the skin. This is the very important point that you should have to consider, since what is a prone and sensitive that leads us into make a mistake. You have to consider 6 points. Read the measurement at the window of the tab measure. Finally, record mid-upper arm circumference to the nearest 0.1 centimeter. Let us see it look in the form of pictorials. Look the first one. Locate this figure shows locate tip of the shoulder. The second and third figure shows is finding the shoulder, tip of shoulder, and tip of elbow. Okay, this the tip of shoulder. This is the tip of elbow. Then this press tab at the tip of the shoulder and pull tab past tip on the bent elbow. Okay, and then mark the midpoint here. Intervals correct tip on tension. It should be correct. Okay, and it one tab too tight. It is not good. It's not good. Okay, in 9 also tab too loose, not fair, not good. Like this, it should be corrected and read. Weigh and measure the child. Okay, weighing using hanging scale. The first one, hook the scale to go on the ceiling or standing in the clinic at a level for the measure. Second, before weighing the child, have the mother take off all the child's clothes. Third, make sure the scale is at 0 scale with the weighing pants or bucket that will be hooked on the scale. Fourth, place child in the weighing pan, hook it on the scale, and let the child hang free, touching nothing. Make sure the child is safely in the weighing pan or bucket. The fifth, when the arrow is steady, the measure reads the child's weight in kg at a level to the nearest 100 gram, for example, 6.4 kg. Have the assistant repeat the weight for the verification and then record it. 7. Don't hold the scale when reading the weight. 8. Calibrate the scale using known weight every week. If the measurement is off by 100 grams or more, change the springs or relapse the scale every week, meaning the program is assigned to every week. But if there are conditions that are forced us to measure individuals or the children for the screening purpose of malnutrition at every moment of weighing, calibration should have to be done. Okay. This shows the pictorial forms of the text that we have discussed. And now let us come to weighing a child using an electronic mother and infant scale. Be sure that the scale is pressed on flat or even surface. To turn on the scale and cover the solar panel for a second, when the number 0.1 appears, the scale is ready. Third, check to see that the mother has removed her shoes. You or someone else should hold the naked child up in blunt. Fourth, ask the mother to stand in the middle of the scale, feet slightly apart, on the footprints if marked, and remain still. The mother's clothing must not cover the display area. Then, fifth, remind the mother to stay on the scale even after her weight appears until the baby has been weighed her arms. 7. With the mother still on the scale and her weight displayed, turn the scale by covering the solar panel for a second. The scale is turned when it displays a figure of a mother and baby in the new 0-point job. Then gently hand the naked baby to the mother and ask her to remain still. After that, the baby's weight will appear on the display. Record the weight for the baby. Finally, be careful to read the numbers in the correct order as though you were viewing them while standing on the scale rather upside down. This is the pictorial presentation of the texts that we have discussed. And general recommendation for measuring weight. The first one is the scale must be calibrated at the beginning of the day using the same standard weight. Okay? Always, it is unforgettable. If there are more than one eligible child in the household, always weigh the lowest one first. Especially this is for survey information. Served in some societies and cold climates, not appropriate or acceptable to remove the clothes and need to follow a different procedures. There are procedures that we remove the clothes and measure them. Then after, with child measure it, and then we differentiate the child's and the clothes kg in different and calculate the net weight of the babies. The scale must be light and robust to be carried easily by the team. Always measure weight beforehand. Measuring length or height. When it comes to measuring length for children less than 87 centimeters in length or below 2 years, the measuring board is placed in the ground and the child is measured lying down. The first one is lay the child down along the middle of the board. Second, the assistant holds the sides of the child's head while firmly touching the hair against the fixed headboard with the hair comb. Third, the measure presses hands on the child's leg to prevent flesh. Fourth, with the legs immobilized, the movable foot is pushed firmly against the child's feet. Fifth, the footboard should be perpendicular to the axis of the board and vertical. Sixth, the length is raised to the nearest 0.1 centimeter. This is the pictorial form of the texts. How to measure height. For children taller than 7 centimeters or above 2.5 years, height is measured with the child standing. Okay, the first step, the child stands upright against the middle of the measuring board. Second, the assistant should check that the child's head, shoulders, buttocks, knee, and heels are touching the board. Third, the child should be looked straight ahead, neither up nor down. Fourth, the movable headboard is pressed firmly against the head, compressing the hair. Fifth, the head is measured after checking that the headboard is labeled. The reading should be the same on both sides of the measuring board. This is the pictorial information. Now let us look at the example how to calculate weight for head. Example 1, a boy weighs 63 centimeters, weight 5.6 kg. Look up the table for a child 63 centimeters length, measuring down. Okay, since it is below 7 centimeters, this boy is considered as below 2 years of age. Okay, based on the information what we have discussed earlier. And then this table shows weight for length. On the left column boys up to 2 years, and this is the length part, and this to the right shows girls to 2 years. This clear. Inside that, this is the median. This is also the median. This is the green, which is a very optimal feeding practice, or is the ideal weight for head of the nutritional status of the children is ideal and it's healthy one. This is also the weight, the length that we have padded, and this also shows to the right and to the left the case that we have compared weight for age. So let us read the table on the same line to the left for boys and look for the figure closest to 5.6 kg. Look, this is 63 centimeters, and then we have 5. Is there? No, there is no. Okay, the child weight 5.6 is less than 5 kg instead. Okay, the figure in the yellow column minus 2 square, but more than 5.3 kg. It's more than 5.3 kg and less than 5.8 kg. Look, this is so. It means it's between minus 2 square and minus 3 square. This shows moderate acute malnutrition. This is mom according to his weight for length. When you come to the second example, to calculate weight for head, a girl had 92.7 centimeters and weighed 10.2 kg. So let us look up the table for a child 9.7 centimeters on head, median standing. In this case, the child's head of 92.7 centimeters needs to be rounded to nearest 0.5 centimeters or to 2.5 centimeters. Look along the road to the right, 9.5 centimeters for girls and look for 10.2 kg. Okay, so from 7 up to 0.5, 0.6, and 0.7 round to 0.5, 0.8, and 0.9 round to the next higher numbers, and 0 up to 0.4 also round to the lowest one. Okay, it's exceptional with mathematical approximation. So let us look this example. This is less than what? 10.3 kg. Okay, that's to the right. Where is 10.3 here? Look, 92.5 is less than 10.3. In the minus 3 this column. Okay, here. Look here it is. Therefore, this child has severe acute malnutrition according to her weight for head. According to the definition, if the child is full in the Z score less than minus Z score, it's considered as severe acute malnutrition. And now let us count the flow chart for the management of severe acute malnutrition. Let us look in detail. Okay. Screening for acute malnutrition in the community will be resulted in measuring the mark of the children 6 to 59 months, and pregnant and lactating women assess the bilateral pitting edema, and also assess for recent weight loss or failure to gain weight information about infants 0 to 6 months. Based on this information, based on our target groups, will diagnose acute malnutrition at the healthy facility, especially at the triage. Okay, assess for bilateral pitting edema in center context, and then let us come to the medium mark, or weight for height or weight for length. Check for medical complications and conduct a RUTF appetite test for children 6 to 59 months. Assess for recent weight loss or failure to gain weight and failing in infants 0 to 6 months. Okay, and also send to IME-NCI according to IME-NCI guideline, and decide where to treat the patient. The patient will be decided when we take the consideration of anthropometric measurements and another nutritional assessment methods like that of clinical for this session. We are categorizing the findings into either severe acute malnutrition or moderate acute malnutrition. Based on the information that we have assessed at triage level or community level, when the child is to be admitted on MAM, there should be what? No bilateral pitting edema, no medical complications. Children 6 to 59 months mark greater than or equal to 11.52, less than 12.5 centimeters, or weight for height greater than or equal to minus z squared 2, less than minus 2 z squared. Pregnant and lactating woman mark less than 23 centimeters, or older people greater than or equal to 60 years mark 18.5 to 21 centimeters. If this data is gotten, or this data have gotten, it is admitted to targeted supplementary feeding program. If this is not, this might going to in some situation for children or pregnant lactating women or older people said to be admitted at severe acute malnutrition, any grade of bilateral pitting edema, either +1, +2, or +3. Children 6 to 59 months mark less than 11.5 centimeters, or weight for height or weight for length less than minus 3 z squared, or older people greater than equal to 60 years mark less than 18.5 centimeters. Older people greater than or equal to 60 years. Okay. Infant 0 to 6 months, recent weight loss or failure to gain weight, or insufficient feeding like that of attachment position in suckling, we are going to check their appetite test. We are going to check their appetite test. When we are checking the appetite test, if the appetite test is good appetite and there is no medical complications, and bilateral pitting edema +1 or +2, severe wasting based on one or weight for height or weight for length, it's going to be directly admitted to OTP since it is considered as severe acute malnutrition without complication, meaning uncomplicated severe acute malnutrition. This is admitted to outpatient therapeutic feeding program. If when we are conducting the appetite test, if there is poor appetite, and if there is medical complication, or if there is bilateral pitting edema +3, not +1 or +2, but +3, or if there is severe wasting, mark or weight for height with any grade of bilateral pitting edema +1, +2, or +3, meaning it is marasmic course. Infants 0 to 6 months with medical complications, recent weight loss or failure to gain weight, or ineffective feeding, and any grade of bilateral pitting edema or any medical or social issues needed detailed assessment. and it's going to admitted stabilization center since it is severe acute malnutrition with complication. And let us come to brief based on the age, especially for infants. Assessment classification of acute malnutrition in infants 0 to 6 months. Okay, we are expected to ask for signs of medical complications, and after that we look and feel, and then we'll look the signs, we'll classify where the site is, and then we'll treat them. If the patient is, when it comes to an asking position, if the patient is too weak to suckle effectively, is there vomiting everything? We are asking this. After that, we'll check for presence of bilateral pitting edema. And then does the infant have bilateral pitting edema? We'll identify or we'll get the information. And then is the infant's weight for length less than minus Z score? We are not expected to check the work. Since we're looking, there is a visible wasting, that we are expected to take weight for length. Secondly, check for medical complications like that of, for treatment purpose, like that of proctitis, intractable vomiting, convulsion, lethargy, unconsciousness, high fever, lower respiratory tract infection, dehydration, persistent diarrhea, so and so forth. Then after that, we'll get any grade of bilateral pitting edema, +1, +2, or +3, or weight for length less than minus 3 square. This classification is some with or without medical complication. Some with or without medical complication for those of infants 0 to 6 months is treated in stabilization center. Now let us come to for infants or children 6 to 15 months. This is also about assessing in the classification of acute malnutrition or level of treatment or for settings of the treatment. Okay, this is to identify the setting of the treatments. And then during the collection of information, we'll ask for sign of medical complications. Is the patient unable to breastfeed, drink, or feed? Is he vomiting everything? Does the patient persistent? Does the patient have blood stool, diarrhea greater than 14 days, cough greater than 14 days, or had contact with TB patients, bleeding tendencies, history of recent sunken eyes, convulsions? These are the information that we have asked. After this, we look and feel, checking the presence of bilateral pitting edema. And does the child have bilateral pitting edema? If yes, is it +3, meaning plus, generalized involving upper arm and face? Check the mark. Is the child's mark less than 11.5 centimeter? Check the weight for it. Is the child weight for laying head less than minus 3 score? Fourthly, check for medical complications. This medical complication like that of infective vomit, convulsion, lethargy, unconsciousness, high fever, especially axillary temperature greater than 38.5, lower respiratory tract infection, and then dehydration. Is there any dehydration? Is that persistent diarrhea? Is there severe anemia? Is there hypoglycemia, hypothermia, especially axillary temperature less than 35.5 centimeters? Severe skin lesion, a sign of vitamin deficiency. This medical complication is assessed, and then after that we'll give the signs. Either bilateral pitting edema +3. This by itself is complicated severe acute malnutrition. This is the sign that is enough for admitted to SC. Secondly, you may get any grade of bilateral pitting edema combined with severe wasting. This will be checked by less than 11.5 centimeter or weight for it less than minus 3 score. Okay. When we say any grade of bilateral pitting edema, it might be either +1, +2, +3. plus more less than 11.5 centimeter or weight for height less than minus 3z square. If these combinations have been found during the assessment stage, we will classify it complicated severe acute malnutrition and it's directly treated to as since it is massive cause. And then the third one is bilateral PT edema plus 1 plus 4 severe wasting more less than 11.5 centimeters or weight for it less than minus 3 z square, and any one of the following medical complications like that: appetite, intractable vomiting, convulsion, lethargy or not alert, unconsciousness, high fever, lower respiratory tract infection, dehydration, persistent diarrhea, severe anemia, it may be hypothermia or hypoglycemia, severe skin lesion or high sign of vitamin deficiency. If one of these is found with bilateral edema plus 1 plus 4, severe wasting might be detected by mark or weight for height square, then it is considered as or classified as complicated severe acute malnutrition and it's going to be treated as stabilization center. When you come to the second broad classification, if there is bilateral pitting edema plus 1 or plus 2 or mark less than 11.5 centimeter or weight for it less than minus 3z square and appetite test passed clinically well and hard, then this is classified as uncomplicated severe acute malnutrition and it is directly admitted to outpatient therapeutic feeding program. If the mark greater than or equal to 11.5 to less than 0.5 centimeter or weight for it greater than or equal to minus z square to less than minus 2 z square, it's class and clinically well and alert. It's classified as moderate acute malnutrition and then it is treated as admitting target supplementary feeding program and counseling appropriate infant and young child feeding practices. If the mark greater than or equal to 12.5 centimeter and or weight for it greater than minus 2 z square and no bilateral pitting edema, there's no acute malnutrition, and we'll say congratulations to mothers or caregivers, and we are counseling based on their age about infant and young child feeding practices, and we'll appreciate their caring of babies, handling of babies. And then let us come to the outpatient therapeutic program for the management of severe acute malnutrition without medical complications. At the end of this session, the students will be able to understand admission procedure for children 6 to 59 months, medical treatment and care for children 6 to 59 months, nutrition rehabilitation for children 6 to 59 months, monitoring during OTP follow-up visits, discharge criteria and exit categories for children 6 to 9 months, and then final discharge procedures for children 6 to 59 months. And now let us come to OTP admission criteria for those of children to manage severe acute malnutrition without medical complications at OTP. Okay, we have seen detailed and clearly the algorithm or the flow charts, but this is separately for better understanding. We will repeat it. And the first one, bilateral pitting edema plus 1 or plus 2, mark less than 0.5 centimeters, weight for less than minus 3 z score, and appetite test passed, no medical complications, clinical well and alert, or referred from SC after supplementation, stabilization, after stabilization. Then we're going to entry categories, new admission. New cases who meet the admission criteria for OTP like this, okay? This criteria, if the child has got this criteria, he'll be added or he'll be admitted as new admission. Readmissions. Readmitted for treatment in OTP due to relapse or return defaulter who meets the admission criteria. If after relapsation or return defaulter, and then they meet the criteria to be admitted for OTP issue, they'll be registered as readmission. And the other category is relapse, cured within the past 3 months and now meets the admission criteria for OTP. Relapse case requires special attention, therefore conduct visit. You have to conduct one visit for the reason to know the relapsation, make the showing of all inappropriate feeding practices, and there might be another cause that we're going to find there. Returned defaulters, defaulting within the past 3 months and has returned to continue treatment in OTP. Returned defaulter should be readmitted if they need the admission criteria. Transfer has moved from any other facility where he or she has receiving or was receiving OTP. When it comes to OTP admission procedure for children 6 to 59 months, take anthropometric measurements to confirm nutritional status, okay? And then conduct medical assessments and medical complications, and conduct an RUTF appetite test for children 6 to 59 months for 30 minutes. Refer the patient who failed appetite test and has medical complications to the SCC. Admit patients with appetite test and no medical complications. And then there are medical treatments for children 6 to 59 months at OTP. Okay, broadly, in OTP program, medicines classified into 2 ways. First one, routine medicines for severe active function and supplemental medicines. The routine medicines will be seen here. 10% sugar water solution, 2 spoons sugar and 100 ml water. Doing referral to SC to prevent hypoglycemia for all ages 50 ml once oral. Then there are amoxicillin, antimalarial, albendazole, mebendazole, measles vaccination and other vaccinations that are given for those children. We come to an amoxicillin on admission of all some patients for all ages with the dose of 25 mg per kg every 12 hours for 5 days. This is oral. When it comes to the anti-malaria, it is on admission. If the positive malaria test is presented for all ages based on the national malaria guidelines, albendazole and mebendazole at the second visit for treatment in OTP. Okay, this is given for greater than or equal to 24 months for albendazole for 100 mg and 500 mg for mebendazole single oral. Bring down supplemental medicines, antibiotics for all severely children to perceived infections, even if they don't have clinical sign of systemic infections. Nearly all children with severe malnutrition have bacterial infections. However, because of reductive adaptation, the usual sign of infection may not be apparent because the body doesn't use limited energy to respond the usual ways, okay? Such as inflammation or fever, no response. Since there is a limited energy, life is at risk for death. When it comes to the vitamin E, we don't give an additional high dose of vitamin E to children with OTP, since RUTF contains an adequate amount of vitamin. A high dose, 50 international units, 1,000 international units into 100,000 international, depending on age of vitamin, should be given on admission only if therapeutic foods given are not fortified as recommended in WHO specification, and vitamin A is not part of other daily supplements given to the child in the past 1 month. But in our country context, there is vitamin supplementation as routine program. RUTF is fortified. All patients who show sign of vitamin deficiency should be referred for treatment necessary. When it comes to the iron and folic acid, iron and folic acid should not be given routinely to children as RUTF contains iron. If anemia is identified, it should be treated according to IMNCI or ICCMC guidelines, and treat should Treatment should be given after 14 days of some treatment. If severe anemia, refer to treatment in necessity. Malaria testing and treatment should be done before the iron and folic acid treatment is given. Zinc. Don't give zinc supplementation to treat diarrhea in some patients in the OTP, since RUTF contains an adequate amount of zinc. When it comes to the nutritional habitation with RUTF, plant meat at OTP or BP handle. RUTF means plant meat is high energy, nutrient-dense therapeutic food that is used to treat some energy. Similar in combination in composition to F100, except RUTF contains iron and is about 5 times more energy nutrient-dense. There are two types: soft lipid pastes, plantinate, or pressure nutrient pair BP100, which is available mainly during emergencies. RUTF has enabled a peak out of the cooling problem. It has minimal water content and doesn't need to be cooked or mixed with water, which prevents growth of bacteria and makes it safe and easy use for outpatient or home management of some. Let's look the amount of reduced therapeutic food or BP100 to give. The amount of reduced therapeutic food to give is 92 grams, such as containing 500 kilocalories. Weight of the child in kg, look this weight of the child in kg. Based on this, there is the sachets that are given for each weight of the child, and then the sachet per weight will be listed here. The same is true for BP100 here, based on the weight in the bar, okay, the bars. When OTP feeding procedures, don't give RUTF to infants 0 to 6 months. They should be exclusively breastfeed. If the child is 6 to 23 months, continue to breastfeed on demand. Mother's milk is best for infants and young children. Feed small amounts of RUTF until the allocated duration is finished. And before eating any other food, it's better to feed breast milk. Encourage the child to eat as often as possible, every 3 hours during the day, if the child is breastfeeding. So for breast milk on demand before feeding RUTF even. Then after, offer plenty of safety drinking water while eating RUTF, and don't mix with RUTF with liquids, as this might cause bacteria growth, okay? Only we give RUTF. Then after, other optimal complementary feeding. The first one, the breast milk, is preferable for those of children 6 to 23 months, and then followed by RUTF, that followed by other optimal complementary feeding practices that are kept in our households. But the only thing that we should not forget is that we don't mix RUTF with other foods in the preparation. When it comes to the monitoring during OTP follow-up visits, mark weight would have to be assessed. Head length if the head center level measure once a month. Okay? If possible, it's better every assessing time. It's better to do. Degree of bilateral PT in edema. Okay? Weight loss. Weight patients who lose weight or have weight fluctuations should receive a home visit and or further medical examination. Clinical signs like that of body temperature, aspiration, dehydration, anemia, skin infection, based on the listed guideline cards, you should have to assess it. Standard medical history, stool vomiting, fever, cough, appetite, any suffered since the last visit. Any action taken or medication given to health condition should have to be monitored. And then repeat the RUTF feeding procedure on every follow-up visit and ask the caregiver to repeat back. Inform the caregiver on the treatment progress. Conduct individual and or group counseling on health watch, especially in LIC parts. During the home visit, there are prioritizations that we should have to first give. One, losing or not gaining weight, has deteriorating into conditions, and is not responding for treatment, and those for children has reduced SC, is absent or defaulted treatment, defaulted patients absent for consecutive visits, especially. And there are some of frequent causes of failure to respond to treatment, inappropriate evaluation of the patient's sales condition or misclinical complications, non-adherence on the RUTF protocols. Okay, these are our priorities. And non-adherence to routine medication protocol, inadequate guidance provided for care, appropriate frequency visits to the health facility and reception of RUTF, inadequate intake of or sharing of RUTF and or medicines with other family members. There is a sharing issue, so we should have to address that in the visit. And let us come to the discharge criteria and exit categories for children 6 to 59 months at OTP. The OTP discharge criteria for children 6 to 59 months, the same anthropometric indicator that is used to identify and confirm some on admission should be used to determine the requirements from that treatment. If the child is admitted with bilateral pitting edema, discharge cured when no bilateral pitting edema for 2 visits and more greater than or equal to 12 centimeters, or with forehead or with forelength greater than or equal to -2 z-square, and clinically well and alive. If admitted based on work, the discharge cured when more greater than or equal to 12.5 centimeters and no bilateral pitting edema and clinically well and alive. If admitted based on weight for length, discharge cured when weight for length or weight for height greater than or equal to -2 z-square and no bilateral pitting edema and clinically well and alive. By the way, if there is a mark less than 11.5 centimeters, not discharged. But the only priority that we want to give is that the first anthropometric detecting is a must to be checked when the discharge type. And there is exit categories like that of entry category. The exit category is going to be cured, died, defaulted, non-responder, or transferred out. When we say cured, has reached the discharge criteria for some treatment. It's great. Dies while receiving treatment in the OTP. That be defaulted, absent for consecutive visits. Default should be confirmed. You should have to know clearly where that defaulting happened. Non-responder doesn't reach the sum discharge criteria after 16 weeks or 4 months in the treatment. The child is expected to be cured before 4 months or before a maximum of 16 weeks. After that, no responder. It's a registered non-responder and discharged. Transferred out. Condition has deteriorated or not responding to treatment according to action protocol and referred to for treatment in SC or moved out to receive OTP facilities. Meaning, it might be transferred to OTP or it might be health deterioration conditions and might be, or she or he might be referred to SC or other sites. When OTP discharge procedure for children, give feedback to the caregiver on the final treatment outcome. Ensure that the caregiver understands how to use continuing medications. Give the final 1 week supply of RUTF ration. Record the exit category on the registration book for some and the OTP treatment and follow-up. Counsel on WASH, good nutrition and dietary practice. Okay, so don't forget it. Advise the mother or caregiver to immediately come back the health facility or health post if the child experiences any sign of deterioration. Refer the caregiver to productive safety net programs and other complementary health and nutrition services. Thank you very much for your attention. We'll continue in next chapter about the stabilization center. For today, it's enough.